The female reproductive system, we started on Friday. And as we say, we need to know the primary sex organs and secondary sex organs. So primary sex organ is ovaries in female and testes in male. So that is really important. As I say, like if you are in a group of medical personnel who are helping a lady to deliver a child, and if you see a child, newborn baby, who has ambiguous external genitalia, like it is not male, it is not female, you have to look for the testes or ovaries. That will determine the sex of that little baby, newborn. Of course, if you cannot see any testes or any ovary, we have to do the karyotyping. Like, is it 48XX or is it 40XXY? But that's the later karyotyping, which comes later. But what we need to check is whether this little newborn baby has got testes or ovaries. That is the most important. Only then we can say this little baby is male or female. So primary sex organ is ovary and testes. Yes, secondary sex organs are uterus, uterine tube, fallopian tube, vagina, vulva, or scrotum in male, penis in male. Doesn't really matter. So whatever you see here, secondary sex organ, it doesn't matter. What we need to know is primary sex organs. That way, determine the, open up the homeworks of the muscles and chart back. Yes, we can. I will open all homeworks. So, primary sex organs, secondary sex organs, important, especially if you are working for the OB/GYN department, because you are going to see this sort of scenario like at some point in your life. Okay, so these are the female reproductive organs. This is the sagittal section, lateral view or sagittal section, which of the female reproductive system. Pubic bone in the front, rectum and anal canal in the back. We have talked about this already. Urinary bladder, which is here. The uterus is falling to the front, which is what we call anterior anteverted uterus. That is normal, especially in ladies with no children, no pregnancy. It could be normal if it is retroverted uterus, but this is a lot more common. And this is what we call anteverted uterus, vagina, vulva, and external genitalia. And the peritoneum is covering the rectum. Part of the rectum is retroperitoneum. It's just come around here, covers the uterus, fold it in between the uterus and bladder, and then cover the urinary bladder and continue to the anterior abdominal wall. While trying to do so, the peritoneum is creating two pouches in female. The first one is in the recto-uterine pouch, rectum and the uterus area, recto-uterine pouch, and this is the vesico-uterine pouch. Yeah, vesico-uterine pouch. It is in between the bladder, bladder, and the uterine pouch. So why are these pouches important? It is important when there is an intraperitoneal infection, when there is abscess formation inside the peritoneum, or when there is a abdominal organ perforations like gastric perforation, intestinal perforation, and if you are washing the peritoneum, you should not forget these pouches because these are the space where the collection can occur and which can easily missed. Therefore, these recto-uterine pouch and vesico-uterine pouches, these are important. And So if you see, this is the anterior view or coronal view. Coronal view, this is the uterus. Look at the wall of the uterus and the uterus endometrium, myometrium, and perimetrium. And I mean, like fallopian tube, which is widened at the infundibulum, isthmus portion, gradually narrow and narrow. When it's just joining to the uterine endometrium, it is what we call isthmus portion. Isthmus portion is the narrowest, and therefore the ectopic pregnancy, like pregnancy outside of the uterine cavity, usually happen in the isthmus portion because it is the narrowest portion of the fallopian tube. And you can see the sheath of peritoneum folding backwards and anteriorly and posteriorly. So if you look from the side, just like everything being covered with the blanket. So the blanket will fold in the front and in the back of the object. The same thing like this peritoneum blanket, which covers the fallopian tube and ovaries from the side. And by doing so, this peritoneal fold, which is folding in front of the fallopian tube and behind of the posterior of the fallopian tube, these peritoneal fold form the broad ligament. Broad ligament include mesosalpinx, mesoovarium, and mesometrium. Yeah. So yeah, that's different portion. Mesometrium means myometrium, so uterus, and mesoovarium. So ovarium is for the ligament for the ovary, and mesosalpinx for the fallopian tube. So the layer for the fallopian tube, layer for the ovary, and layer for the uterus. And keep going then, uterus body. And this, look at that ureter. Ureter is come from the kidney. From the kidney, all the urine has been collected in the kidney. It takes the ureter, takes the urine from the kidney to the urinary bladder. And the way it has to come into the retroperitoneum to the in front of the uterus, you can see the ureter. Ureter is going in the two peritoneal folds, which is covering the uterus fallopian tube. And therefore, when they do as surgery for the uterus, this ureter can get easily damaged. Ureter can get easily damaged because of the proximity of the ureter to the uterus. And when we are ligating the uterine blood vessel, which is just here, look at that uterine blood vessel just here, which is coming to the uterus. Okay, the good until Thursday, my daughter and I received yes. Okay, so ureter, the proximity, I want you to remember the proximity of the ureter, which is going to the urinary bladder, Here, urinary bladder is just here, and the uterine artery here, look at the uterine blood vessels here. So when we do the hysterectomy, like removing the uterus, which is called hysterectomy, then we have to ligate the uterine artery, or that we have to ligate all the feeding vessels for the uterus. Then that is where we damage the we can damage the ureter. So that's the proximity between the ureter and the uterine artery when we're doing the hysterectomy. So this anatomy important is really important. And we said uterus has three layers: endometrium, which is the innermost, myometrium, which is the muscle layer, and perimetrium outside layer. And you can see the fimbria here, which is just covering the ovary. Look at that, the way the fimbria of the fallopian tube, which is covering the ovary. So ovary is attached to the uterus with the ovarian ligament as well. So look at that, you know, quite a lot of structures trying to attach each other. And now we can see the round ligament of the uterus. That is the what you call the spermatic cord in male, and the round ligament of the uterus in female, which is transpassing the inguinal canal. So round ligament of the uterus here, which is just like, you know, a thick cord, fibrous cord here, which is going through the inguinal canal, come out from the external or superficial inguinal ring and go to the vulva. So this round ligament might have played a role in supporting the uterus in its position. So look at the uterus, ovary, fallopian tube, and the blood vessel and the ureter. That is what I want you to remember from this diagram. So that is really important. This anatomy, take a photographic memory, and whenever you have to walk around this area, you have to be mindful with what the structures you need to be careful. And cervix, external os, internal os, cervical canal, and this is the vagina. Okay, so ovaries, they are pair organ, right ovary and left ovary. The size, okay, it might varies, and it is the blood supply for the ovary is from ovarian arteries. Where do we come from? These ovarian arteries, they come from abdominal aorta. Yeah, you know that they come from the abdominal aorta. Testicular artery, they come from abdominal aorta. Ovarian arteries, they come from the abdominal aorta. They are paired arteries of the aorta. The paired arteries are renal artery, directly going to the kidneys, right kidney and left kidney, and coming up obliquely from going to the gonads. Yeah, so, and ovary is a retroperitoneal organ, so it is not inside the peritoneum. And you have seen the meso-ovarian and broad ligament and suspensory ligament, ovarian ligaments, they are all attached to the ovary. That means when you are doing an operation, going to take out the ovary, you have to cut all these ligaments. And it has got cortex and medulla. Like every rounded structure we have, like cortex and medulla, adrenal cortex, thymus gland, lymph node, everything, kidney, cortex and medulla, outer cortex, inner medulla. It has cortex and medulla. So ovary, cortex, in the cortical region, we have oocytes. So these are the little, going to become the little follicle and ovum. So that is in the cortex. And one oocyte, one follicle, mature follicle, will spit out one ovum, or might be two. And the medulla, which is the more central portion of the ovary, it has got blood vessels and nerves. So let's look at that diagram. So this is the ovary, and the outermost layer is germinal epithelium. Germinal epithelium is just like a epithelium layer, which is usually squamous epithelium, or might be some like cuboidal epithelium, but nothing more than that. And the outermost layer is germinal epithelium, and this tunica albuginea. So we have the testis equivalent tunica albuginea in the ovary. And then cortex, look at the cortex here. Inside the cortex, we have the follicles here. Look at that, follicles here. And follicles will gradually develop from primary follicle to secondary follicle to finally become mature follicle and then finally ovulate. The central portion of the ovary is called medulla. Inside the medulla, we only have blood vessels and nerves. So the medulla is for blood vessel and nerve. It is not like adrenal gland. Inside the adrenal gland, in the medulla, we have the layer adrenal medulla, which is secreting epinephrine or epinephrine. Not like that in the ovary. So now we are going to talk a few little things which we know about uteri tube or fallopian tube, or in other words, Selpings. So it has called fimbriae portion. You can see the little finger-like projection, which is covering the ovary. And infundibulum is just the opening into the, which is the first part infundibulum here. The first part of the fallopian tube is infundibulum. Infundibulum, it is open into the peritoneum. So it is amazing. The ovary is retroperitoneal organ. Fallopian tube is covered with the peritoneum, so it is not inside the peritoneal cavity. But when the ovary ovulates, it's trying to ovulate into the peritoneal cavity. And this infundibulum portion of the fallopian tube and this fimbria, they try to cover, and wherever this ovary try to ovulate, they try to catch it. So it is amazing. It is amazing arrangement. I don't know why they have to do it, but that's the way a human being is. So this ovary, which is outside the peritoneum, fallopian tube, which is outside the peritoneum, but this fallopian tube, the end portion, infundibulum, and the fimbria, they are just close to the ovary, and the ovary spit out the ovum into the peritoneum, and this infundibulum and the fimbriae try to catch it and put it into the fallopian tube. Ampulla, as you see, it is the site of fertilization. Ampulla is the site of fertilization, and which is the lateral 1/3 of the fallopian tube, like the medial 1/3, middle 1/3, and lateral 1/3. Lateral 1/3 is for the fertilization. The isthmus portion is the narrowest. So I want to make sure you guys have some knowledge just about this, which the importance of which portion of the fallopian tube, which is related to the clinical implication. And the uteri tube is covered by the mesoselpings. It is a site of the ectopic pregnancy. So ectopic pregnancy can happen anywhere along the fallopian tube, or along the anywhere around here, of course, anywhere around here. So, but usually ectopic pregnancy is in the isthmus portion. So that is really sad, you know, the isthmus portion get caught, this the fertilized ovum get caught. So usually at about day 3, it is here, and by day 4, as we learn, by day 4, this fertilized ovum is in the uterine cavity. So it is day 3, like where it is blocked around the isthmus portion. And when we talk about uterus, different portions of the uterus, fundus, which is the dome-shaped portion, body, this main body, isthmus portion, and cervix. So let's look at what we know what we are talking about. This is the fundus portion of the uterus, and this is the whole body of the uterus, and the isthmus portion and the cervical portion. Isthmus portion, and isthmus is here, isthmus is here, isthmus portion of the uterus just before it comes into the cervix, and this is the cervical portion of the uterus. And in the cervix, we have the external os and internal os and cervical canal. Usually, cervical canal is filled with the cervical mucus. So this is the mucus secretion. But in the mid-cycle, so let's say if someone has a 28-day cycle, so on day 14, mid-cycle, there is ovulation happens around mid-cycle, and the mucus plaque of the cervix, mucus plaque of the cervix is the most thin and light, so that the sperm can go through the cervix and get into the uterus and along the fallopian tube. So that's the nature, and other times like early cycle or late cycle, this cervix is filled with the thick mucus plaque, which is difficult for the sperm to penetrate. And the layers of the uterus, perimetrium, myometrium, and endometrium. We all know that already. And uterus, perimetrium, myometrium, endometrium. Endometrium, what is the function of the endometrium? Of course, it is secretory, isn't it? Uterus always making secretion, and it is for nutrition for the little embryo to get into the endometrium. So the purpose is it is for secretion and nutrition of the embryo, and therefore we need to use the columnar epithelium for the endometrium. If we use the squamous epithelium, that will be a disaster for the little embryo to embed in the uterine endometrium. So to give the embryo a good environment, we will use the columnar epithelium, which is loss of secretions and loss of nutrients, and so that the little embryo can survive. So endometrium can be further divided into basal layer and functional layer. What does it mean? Like the functional layer change with the cycle of the menstruation, with the uterus cycle. And the basal layer doesn't really change much. So basal layer is giving the support, and the functional layer, the outer functional layer, give the what shall I say? Outer functional layer give the changes during the cycle. So every month after the menstruation, the whole functional layer will break down and come out as menstruation, and this basal layer proliferate more and more. And after the menstruation, this functional layer gradually builds up. And so that is why we call that functional layer. And uterus is supplied by the uterine artery. Uterine artery comes from the internal iliac artery. So as you remember, the abdominal aorta divide into right and left common iliac arteries. This right and left common iliac artery will divide into internal iliac for the pelvic and continue and pass under the inguinal ligament and the name change from external iliac artery into femoral artery. So the name change once the same artery passing under the inguinal ligament. So just distal to the inguinal ligament is femoral artery, and proximal to the inguinal ligament is external iliac artery. So internal iliac artery give branch as the uterine artery. So it is a pretty heavy blood vessel which flows quite a lot of blood, especially in the pregnancy. So this is the uterus, perimetrium, myometrium, endometrium. Endometrium has two layers, basal layer and functional layer. Look at that. That is the histology slide. So now you can see the endometrium, which is made of functional layer of the endometrium and basal layer of the endometrium. Basal layer of the endometrium remain the same throughout any menstrual cycle or even during the menstruation, but it is the functional layer of the endometrium which change with the uterine the menstruation. So look at that. Look at the blood supply. It is coming from the uterine artery, and these branches go through the muscle layer, myometrium layer. When the artery is passing along the myometrium, it is pretty much straight. Look at the vein are also pretty much straight. And once it gets to the basal layer of the endometrium, these arteries become tortuous, like a spring, so that it can accommodate, stretch out. It can stretch out especially when the lady has pregnancy. So it's like tortuous and spiral artery, it becomes straight, and then finally becomes straight, and then get into the functional layer of the endometrium. Look at the blood supply of the uterus endometrium, which is highly vascular. And we also have the glands which originate from the mast cell layer and opening into the uterine cavity. Yes, we will study later the changes of the uterine cavity, uterine endometrium with different days of the menstrual cycle. So let's move on. What are the structures supporting the uterus? If we look at that again, if we look at the uterus here, it is just hanging inside the pelvic cavity. And if you look at here, of course, it is hanging like that inside the pelvic. Can this uterus come down, prolapse, come down through the vagina, outside the vulva, external genitalia? Yes, it could happen. But the incidence is gradually lower and lower because many years ago, like people, they have a lot of children, and with every childbearing, I believe, these pelvic floor muscles get weak, and the uterus became more and more retroverted, and retroversion give the direct flow of the uterus into the vagina. Anteversion, it is bent forward. There is an angle between the vagina and the body of the uterus, so it is less chance for the uterus to prolapse into the vagina. But like with the repeated childbearing, all the ligaments has been stretched inside the pelvis, like all these ligaments, like all broad ligaments, wrong ligament being stretched after multiple pregnancy, and then the uterus can prolapse into the vagina, through the vagina, and come out through the vulva. Yes, it could happen, but the incidence is gradually less and less. And what are the structures supporting the uterus in its position? So let's say in a normal person, why this uterus doesn't come out through the vagina, through the external genitalia? Of course, we need to know the structures supporting the uterus. So if you can remember all the ligaments around, which we show during the diagram, then it helps. The mesometrium, so that's the lateral cervical cardinal ligament, the round ligament which we saw, which is the opposite of the spermatic cord, the round ligament, and the urogenital diaphragm and pelvic diaphragms. So let's look at the structures, which were mesometrium and a few other ligaments here. So look at that. This is the mesometrium. So this is the peritoneum, as I say, which fold in front of the ovary and in front of the fallopian tube and posterior to the fallopian tube, two fold, and then stack together again and stack to the body of the uterus, isthmus of the uterus. So all these peritoneal fold pulling the uterus to side by side. By doing so, the uterus has less chance to drop into the vagina. At the same time, the round ligament pulling the uterus forward, and all the cervical and cardinal ligaments around here, they are giving the support to keep the uterus in its position. And at the same time, we have a few other muscles from the pelvic floor, which we call urogenital diaphragm, which we call pelvic diaphragm. And these muscles inside the pelvic cavity, they are also supporting the uterus so that uterus cannot drop down and come out through the vagina. So now we need to study the urogenital diaphragm and pelvic diaphragm. Okay, so now let's have a look. So just looking into the private parts of the human being, and if we strip the skin off, let's take the skin of both the male and female skin off, then this is what we are going to see. So after removing the skin, this is what we are going to see. We are going to see a few muscles here. And that is what we call muscles of the superficial perineal space. Of course, we are looking at their perineum. We are looking at the human perineum of both male on the left and female on the right. And if we remove the skin off, then this is just underneath the skin. This muscle layer is just underneath the skin. And that is what we call the superficial perineal space. What muscles can we see? What muscle can we see? Of course, in the back here, we can still see the buttock muscle, which is the gluteus maximus. So we are seeing the gluteus maximus muscle here because we can see the buttock muscle here. Okay, so buttock muscle is not in the perineum, it is in the gluteal region. So we will forget about the buttock muscle. And in male, we can see the penis, and in female, we can see the vagina. And now what we need to know is we need to look at the muscles which is just there in the superficial perineal space. Oh, look at that, levator A9. This levator A9 in the perineum, which is in the superficial perineal space, is really, 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 really important muscles. So levator A9 muscle, I want you to remember that levator A9 on the right and on the left and on the right. And this muscle is going across here, from the right ischium to the left ischium. That is what we call superficial transverse perineal muscle. Superficial transverse perineal muscle. And then you can see the ischio-cavernosus. From the cavernosus muscles from the penis going to the ischium, ischio-cavernosus muscle, and this is the bulbospongiosus muscle. Hey, so ischio-cavernosus muscle here, ischium to the cavernosus muscle, bulbocavernosus muscle here around the vagina, and levator A9 muscle, and superficial transverse perineal muscle. So at least, even if you cannot remember all the muscles, I want you to pick up as much as you can, especially for the levator A9 muscle, because this is the levator A9 muscle. This is the muscle we need to work hard after the delivery of the baby, so that we don't have any problem with the urinary incontinence, or we have to strengthen. It is part of the pelvic floor muscles exercises to prevent the incontinence. So this levator A9 is really important, and it is just closing around the anus and rectum and anal canal. So this levator A9, which is the pelvic floor muscle, which is looping around the anus and rectum, which is really important, which is in the superficial perineal space. Okay, now it is the urogenital diaphragm. Why am I saying this? Because these are also important in the support of the uterus. So this first layer, which is the superficial perineal space, we see the levator A9 muscle. This second layer, we see the urogenital diaphragm. Look at that. Now, in the superficial perineal space, we saw the superficial transverse perineal muscle. Superficial transverse perineal muscle. In the urogenital diaphragm, we will see deep transverse perineal muscle. Hey, all these things are important. Superficial transverse perineal muscle, deep transverse perineal muscle, levator A9 muscle. And now you can see the anus, which is surrounded by the external anus sphincter. You can see the anus, which is surrounded by the external anus sphincter. As we know, external anus sphincter is the skeletal muscle, which is under voluntary control. So external anus sphincter is the skeletal muscle, which is under voluntary control. So now you can see the urogenital diaphragm, which is made of external deep transverse perineal muscle, and the external urethral sphincter, external anus sphincter, they are all in the second layer, which is in the urogenital diaphragm. So now, once this is the superficial perineal space, and now once we go to the second layer, we go deeper into the pelvic cavity from outside, from skin. This is the skin, and now this is the removal of the skin, first layer. If we remove this layer, this is the second layer, urogenital diaphragm. So now once we get to the urogenital diaphragm, what is the big difference between male and female? There is not much here. Of course, in the deep transverse perineal muscle here, in female, there is an opening for the vagina. Not here. It is in the right and left deep perineal muscle meet as a tendon, but not in the female. It's open as a vagina. But other than that, what is the big difference between male and female? Not much. Okay, let's move into the very deep layer. So number 3 layer, or in other words, we will change upside down, because this is, we are sitting outside the peritoneum and looking at the peritoneum from outside. Now we will go into the pelvic cavity. So this is the pelvic cavity, looking from inside the pelvic cavity. So this is the right side, and this is the left side. This is anterior, this is posterior. We can see the vertebral column here. So now we have changed the view. This is looking into the pelvic from the abdominal cavity. Yeah, so this was, we are looking from the outside of the, in between, we are sitting in between the legs and looking into the perineum. This is from the abdominal cavity looking into the pelvis. And this is the right side, this is the left side. And so pelvic diaphragm, hey, look at the pelvic diaphragm, which is made of levator ani and coccygeus. Levator ani is made of 3, but at least I want you to remember 2, pubococcygeus and iliococcygeus. Look at the pubococcygeus, iliococcygeus. So it tells the muscle origin and insertion already. Pubococcygeus, it comes from the pubic bone going to the coccyx of the coccyx, which is the extension of the sacrum. Iliococcygeus, which is coming from the ilium going to the coccyx. Pubococcygeus, iliococcygeus. And this is the coccyx. And that's muscle, 2 muscle, this pubococcygeus and iliococcygeus, which make the sheath of the levator ani muscle. And of course, we have to add the coccygeus muscle. So pubococcygeus, iliococcygeus, just pure coccygeus muscle, which is combination of 3 is called pelvic diaphragm, which is this one, yeah, levator ani, which is made of pubococcygeus, iliococcygeus, and if we add the coccygeus muscle, we have the what do you call that? Pelvic diaphragm. So pelvic diaphragm here, pelvic diaphragm is made of levator ani, which is made of pubococcygeus, iliococcygeus, and coccygeus. So pelvic diaphragm is made of pubococcygeus, iliococcygeus, and coccygeus muscle, which is the outermost layer after the skin. The The second layer is urogenital diaphragm. So we have two diaphragms inside the pelvis. One is the urogenital diaphragm, and the other is the pelvic diaphragm. So these muscles are all skeletal muscles. They are important. We need to make it stronger, especially after the childbearing, especially for the prolapse of the uterus or urinary incontinence, especially after childbirth, labor. All right. And you can see the urethra, which because the bladder is at the far anterior, middle is uterus, so we can see the vagina, and the last is the inner canal here we can see. And these are the some origin and insertions. Origin and insertion. Of course, origin and insertion, levator ani. Levator means leave, elevate. And ani, anus, means it's raise the anus, so it's just squeeze the anus. And its origin and insertion, as we know, from the pubic, from the ileum going to the coccyx, because it is made of ileococcygeus and pubococcygeus. And that's the coccygeus. So these muscles are supplied by the sacra 3 and 4, sacra 3 and 4. And deep transverse perineal muscle, which is the muscle layer of the urogenital diaphragm, and the external urethral sphincter, it is supplied by the pudendal nerve. So deep transverse perineal muscle, external urethral sphincter supplied by the pudendal nerve. So now again, pudendal nerve comes into your mind. Pudendal nerve is for the internal pelvic muscles. It is really important, pudendal nerve. Right. And ischiocavernosa, this is just for completeness. It is not really important. If you have time, just have a look. So now, if we look at this superficial perineal space again, if we draw a line from the back of the rectum, here, perineal body, go to the ischium, which is the bone bump, which we can feel. And this bony bump is something we are sitting on, which is called ischium. And from the ischium to the root of the penis, from the root of the penis to the ischium, from the ischium to the perineal body. So this is the perineal body at the posterior aspect of the rectum. Now we have a diamond shape. Now we have a diamond shaped structure. This is what we call the perineum. So the same thing for the lady, from the perineal body, which is at the musculotendinous region, you can feel it by yourself, posterior to the anus. Draw a line from here to the ischium, which is the bony bump we can feel, and it is the bony bump we are sitting on, and go to the clitoris, from anterior to the clitoris, and then clitoris come to the ischium, and now we got another diamond shape. And this area is what we call perineum. So perineal injury means injury in this area. Perineal hematoma means blood clot in this region. And what are they going to damage? Of course, they are going to damage the muscle in the superficial perineal space, muscles in the deep perineal space, which is the urogenital diaphragm, and all the structures involved, which is the anus, vagina, and urethra. So the perineal injury is a big question in later life, especially for those who specialize in this area. But at the moment, what we need to grab is we need to know where is the perineum is. A perineum is coming from the perineal body, ischium, root of the penis, ischium, and then perineal body. So that's now this create a diamond shape. This diamond shaped area is called the perineum. So this is the external genitalia of the female, which we all know. And so this is the diamond shape which we have created from the perineal body, which is posterior to the anus, the ischium, which we are sitting on, which is just in front of the clitoris. So this is now a diamond shape. This diamond shape, that is what we call the perineum. And here, what I want you to take is, we have little Bartholin's gland just at the entrance of the vagina. And this Bartholin gland can get irritated, inflamed, and can get infection, which is what we call Bartholin's abscess, the pus formation in the Bartholin's gland. So usually the presentation is starting with the discomfort around the entrance of the vagina, in the vulva, and you can feel a little bump and gradually get bigger and bigger, and then finally become painful, swollen, and the pus come out. That is the Bartholin's gland's abscess, which is clinically important, which is not uncommon in female. Okay, and now we can see a few little nitty-gritty things like greater vestibular glands and the part of the vestibule, the clitoris. Hey, you know, that's not a big thing to remember, not much to remember. So now we are getting close to the end of this lecture. The spermatogenesis, which is a big topic, we can talk about like about 2-3 hours about spermatogenesis, and the same thing, oogenesis, like the development of the ovarian follicle, which is again like 2-3 hours topic. Spermatogenesis, let's take it brief. Yeah, let's take it brief. Spermatogenesis, formation of the sperm. And as we learned from the previous lecture slides, we know that 4 million of sperms per day formed, and it starts from the stem cell, sperm forming cell, which is what we call spermatogonia. Spermatogonia will develop into primary and secondary spermatocyte, and finally they change into spermatids, and finally they become sperm. And what we need to remember is Sertoli cells, sustentosites, give nutrition to spermatogonia. Yeah, so like we talk about that in the male reproductive organs, which is inside the seminiferous tubules. Yeah, seminiferous tubule, the testes, tunica albuginea, split the testes into multiple lobules, about 250-300 lobules. Inside each lobule, we have the the tube, seminiferous tubules. In seminiferous tubule, we talk there are 4 cells. 4 cells, number 1 is Sertoli cell, number 2 is spermatogonia or sperma-forming cell, and number 3 is interstitial cell or Leydig cell, and number 5 is a myoid cell, so smooth muscle-like cells. So 4 cells in the seminiferous tubule. That's what we talk about. So now we are talking about this Sertoli cell from the seminiferous tubule. This Sertoli cell gives nutrition to the spermatogonia, and interstitial cell, just a reminder, Leydig cell, which produce the androgen. The main form of androgen is testosterone. That is from the that is what we should know about spermatogenesis. Okay, next, oogenesis. Again, oogenesis is a very interesting topic, and it is about like 2-3 hours lecture. So we are going to just make it a little bit short. And stem cell, so the stem cells, which is called oogonia, and oogonia will gradually develop into primary oocyte and then develop into secondary oocyte. And depending on during the phase of the menstrual cycle, in the follicular phase, it will the ovaries will gradually develop one follicle, and then at the end of the follicular phase, it will just spit out the ovum. So let's go and talk about that. Oogenesis produces single ovum and 3 polar bodies. Oh, what are these? I will explain that later. Only after the completion of meiosis 2, it is called ovum. So this is a lot about oogenesis. So let's have a look. So this is the little ovary which gradually get mature, and then finally will come out as a ovulation into the peritoneal cavity. So this is the ovulation, and finally it will, the remaining follicle, the remaining ovarian follicle will be left behind inside the ovary as the corpus luteum. Yeah, corpus luteum. Let's go and study a little bit. So what I want you to remember is, I want you to remember this slide. So this is the oogenesis. Look at that before birth. And now infancy and childhood. And now after the puberty until menopause. So these little ovaries inside the ovum has 3 different phases. One, they were before birth, from birth up to like before puberty, and after the puberty. So 3 phases. What's happened inside the mother's womb? The stem cell, which is called oogonia, will go into primary oocyte. That's it. So when a little baby, female baby is born, in their ovaries, they will have primary oocyte. So little female baby is born with the primary oocyte in their ovaries. And during the infancy, look at that. The primary oocyte remain as primary oocyte. What an amazing thing. So like this primary oocyte remain the same. And then only after the puberty, this primary oocyte will gradually change into secondary oocyte, and secondary oocyte, and then finally mature into ovarian follicle mature, and then finally just come out the ovulation happen. And what I want you to remember is during that time, after the puberty, then we form the first polar body here, and after that we form second polar body. So oogenesis create 3 polar bodies here. This first polar body will divide into two polar bodies, and this ovum can divide, and then 1 polar body and 1 ovum. So what I want you to remember is oogenesis give 3 polar body and 1 ovum. So that is the final result. And meiosis 2 is complete only after the fertilization. So that is, this meiosis 1 is here, which starts meiosis 1. Where is the meiosis 2 here? Meiosis 2 is complete only after the fertilization. So that is what I want you to remember is oogenesis at the end, ovum and 3 polar bodies, and meiosis 2 completes only after the fertilization. The sperm penetrate the ovum. So now we have to remember 2 cycles of the female reproductive system. The first one is uterine cycle. Uterine cycle is the cyclical changes of the uterine endometrium. cyclical changes of the uterine endometrium. Yeah, it is changes in the endometrium with the menstruation, before menstruation, just before menstruation, and then menstruation. So this is what we call the uterine cycle. Uterine cycle has 3 phases. Menstruation phase. During the menstruation, the shape of the uterine endometrium. Proliferate after the menstruation, the endometrium gradually proliferate and more cells formation again. And number 3 phase is second secretory phase. So that is after the ovulation phase. So it's 11 o'clock, right? Okay, guys, I will give you like 15 minutes break. Cycle is change in the uterine endometrium. Of course, when we say uterine endometrium, we are talking about the functional layer of the uterine endometrium. And the functional layer of the uterine endometrium change like, like with the different days of the menstrual cycle. So we start with the menstruation phase. So during the menstruation, the all functional layer of the endometrium, they just break down and they just shed away as a menstruation. So that is the first stage of the uterine cycle, which is the menstrual phase. After the menstruation, this uterine endometrium, which is the functional layer of the endometrium, which gradually proliferate again and again and again for about, let's say, for about 14 days. It is the preparation for the uterine endometrium to accept the little fertilized ovum, if there is any. So it is just waiting for the fertilized ovum to come into the proliferative. And as we know, this implantation, the fertilized ovum coming into the uterine endometrium at about 7 days, like 14 days, it's going to be complete. So this proliferative phase, the functional layer of the uterine endometrium gradually prepare its bed. And let's say if there is no implantation, and after the mid-cycle, the hormonal changes happen, and the first 14 days, because of the estrogen, the uterine endometrium proliferate, and after 14 days, then there is no fertilization, then there is gradually decline of the estrogen and progesterone, and that's finally at the end of the second 14 days, which is, let's say, about 28 days from the menstruation. Nothing happened, there is no more progesterone, and then this uterine endometrium, which has been building up, gradually break down and come out as a menstruation. Yeah, so the first 14 days proliferative phase, and let's say if it is a 28-day cycle, the second 14 day is more like secretory phase. It is more like progesterone phase. First 14 days proliferative phase, it could also be called estrogen phase because more estrogen, and second 14 days more of the progesterone. So this is the changes in the uterine endometrium. That is what we call uterine cycle. But we have to be careful with the difference of the ovarian cycle. Ovarian cycle is changes in the hormone in the body with the changes in the ovary and ovum itself. So if you look at that, we have the follicular phase and we have the luteal phase. What does it mean? So this is the first 14 day, and day 14 we have ovulation, and after ovulation we have another 14 days. So let's say this is day 28 days menstrual cycle. And day 14, we have ovulation. So first 14 days, what's happened is our primary follicle, look at this little primary follicle, will gradually develop into secondary follicle. And secondary follicle will gradually develop into mature ovarian follicle. And day 14, we have ovulation. So the first 14 days is called follicular phase. And second 14 days after the ovulation, this ovarian follicle is left behind as a corpus luteum. Corpus, which is body, luteum means white body. Actually, it is not really white. It is a little bit yellow gold color. So corpus luteum continue to secrete progesterone, and finally, if there is no fertilization and implantation, this corpus luteum will gradually regress, will gradually break down, degenerate corpus luteum, and finally cannot provide any more progesterone. And this thick uterine endometrium, which is made of the functional layer of the endometrium, which gradually break down and come out as the menstruation. So this is the ovarian cycle. Don't confuse with the uterine cycle. Uterine cycle is changes in the uterine endometrium, and ovarian cycle is changes in the ovary. Start from the very small little primary ovarian follicle, finally become into ovulation, and the remaining left portion is called corpus luteum, and this finally corpus luteum gradually regress. Because this corpus luteum is providing the hormone, and therefore we say this is second 14 days after the ovulation is called luteal phase, and first 14 days it is the formation of the ovarian follicle, therefore we will say follicular phase. So that is the ovarian cycle, and it is different from the uterine cycle. So let's look at the changes, hormonal changes in our body. Then if you look at that follicular stimulating hormone, FSH, FSH is high here during the follicular phase. So follicular stimulating hormone, the job is to stimulate the follicle. Therefore, it is called follicular stimulating hormone. Follicular stimulating hormone comes from the pituitary gland. Pituitary gland secrete follicular stimulating hormone, which will stimulate the follicular maturation inside the ovary, which way this follicular stimulating hormone is responsible for changes from the primary follicle to secondary follicle to mature follicle, and then finally, as I say finally, then follicular stimulating hormone gradually, once the follicle gradually mature, it gradually go down, and finally luteinizing hormone, LH, luteinizing hormone from the pituitary kick in. It is very short, bam! It is not like it's just shoot up. By doing so, just spike of luteinizing hormone just push the ovary out of the ovarian follicle. Look at that. And this luteinizing hormone just go up short and then come down. It is very short. And this spike of luteinizing hormone kick the ovum out of the ovarian follicle as an ovulation. And finally, this luteinizing hormone will gradually cool down. So that is the ovarian cycle. So let's look at the next slide. If you look at the uterine cycle, we said menstrual phase, proliferative phase, and secretory phase. Look at the functional layer of the endometrium, and this is the basal layer. So hey, look at that basal layer, which is the deeper pink color, doesn't change anything. It is the basal layer. It is always there to produce the functional layer. So basal layer doesn't change. But look at the functional layer. The menstruation phase, after the menstruation, the functional layer is pretty much zero. Yeah, you can see that. It's not thick at all. And with time, With the proliferative phase, because of the estrogen, this uterine endometrium functional layer gradually builds up. Look at the, let's say day 14 ovulation there, we will have corpus luteum, and because corpus luteum provide more progesterone, so this maintain the uterine functional layer, endometrial glands more and more. And finally, the degeneration of the degradation of the corpus luteum, lack of progesterone, no more support, and this gradually break down, and this all the blood and the functional layer of the endometrium come out as a menstruation. So that is what we call uterine cycle and the ovarian cycle. So let's look at and of course we have seen the luteinizing hormone and follicular stimulating hormone changes. So what are the estrogen and progesterone changes here? Look at that. Estrogen gradually, as the proliferators go on, the estrogen gradually come up. Actually, as the estrogen gradually builds up, then the uterine endometrium gradually build up. Look at that blue color. So as the estrogen gradually builds up, uterine endometrium, functional layer we are talking about, gradually builds up. And finally, after the ovulation, day 15, because of the formation of the corpus luteum will secrete progesterone, and the progesterone will gradually build up more and more, and it will maintain the endometrium. By that time, estrogen is going down already, might be a little bit fluctuating, but estrogen gradually shoot up. And near end of the menstrual cycle, this corpus luteum gradually regress and degenerate. And as the corpus luteum degenerate, then this progesterone level gradually go down, and this endometrium cannot be maintained, and it comes out and shed as the menstruation. So uterine cycle, ovarian cycle, changes with the follicular stimulating and ovarian hormone, and changes with the estrogen and progesterone. They are all important. They plays a big role, you know, when you go and study the OB/GYN, and like me, it is really become, they will make it more and more complex. So we need to understand at least some basic here. Okay, so next slide. So this is the sperm, and we know that at the tip of the sperm we have acrosome. This acrosome is useful for the sperm to penetrate the ovum, to get into the ovum, and this, using the acrosome penetrating into the ovum, it is called acrosomal reaction. By using acrosome, the sperm can penetrate through the wall of the ovum and get and meet the female chromosome. Okay, so that's the acrosomal reaction, which is not much to talk about. Yes, if we talk, it's quite a bit. So now we will talk about the breast, because breast is just as modified sweat gland, but it is involved in it changes with the menstruation, it changes with the pregnancy, therefore they have included in the reproductive system. So breast is a modified sweat gland. So sweat, hey, it is nothing more than a sweat gland. And of course, it provides milk, and which is nutrition for the baby. And we need to know the boundaries of the breast. So it extends from top to bottom. It extends from second rib to sixth rib. That's simple. So how about medial and lateral? Medially, it is from the sternum. Laterally, from the mid to the mid-axillary line. Mid-axillary line means your axilla here. So anterior axillary line, which is the anterior axillary fold, posterior axillary line, which is the posterior axillary fold. In between these two axillary lines, we have the mid-axillary line. So it extends to the mid-axillary line. It is lying on the pectoralis major. We know that the anterior chest wall muscle, pectoralis minor, of course, underneath the pectoralis major, we have pectoralis minor, serratus anterior, as we saw, like it is originating from the ribs, going backwards to the scapula, which is the pushing muscle, serratus anterior, and external oblique, which is the one of the abdominal wall muscles. So it is lying on these muscles. It has nipple and areola. It has 15 to 25 lobes, and it has suspensory ligament. What am I talking about? Let's have a look at here. So the breast, this is the left breast. It is at the top, it will be second rib. At the bottom, it will be sixth rib. Medially, it is sternum. It is just lateral to the sternum. Laterally, it will go to the mid-axillary line. It has got nipple. It has got areola, nipple and areola here. It has got lobules. How many lobules do we have in our breast? It is like 15 to 25. Let's say 20, yeah? 20 lobules plus or minus 5. And 20 lobules, lobe here. And inside the lobe, we have finally get the lactiferous duct here. Lactiferous duct and lobule containing alveoli here. So that is our female breast. And look at that suspensory ligament, the ligament we talk about here suspend, pull the breast upward, suspensory ligament here, suspensory ligament here. These are the suspensory ligaments here. So that's all about breast. I have to say, when we talk about cancer of the breast cancer, which is very common. So in these lactiferous duct, where is the lactiferous duct? When they say ductal carcinoma, can carcinoma mean cancer? Ductal carcinoma mean cancer in these duct. You look at the duct, how small are they? In these little small duct, they can get cancer of the duct, and that cancer can present as the bleeding from these little duct and can come out with the bleeding from the nipple discharge, which is like a blood stain. That is something we need to be careful with. So ductal cancer or lobular cancer. So these lobe, the cancer has involved in these lobe. That is what they call lobular cancer. If the breast cancer extends downwards, and it can go and attach to the pectoralis major. So that's why if a breast cancer, if you are seeing a patient with the breast cancer, and if that cancer cannot mobile over the pectoralis, then that is a disaster. It has invaded into the pectoralis major muscle already. Okay, so now this might be a final slide. That is the descent of the testes. Descent of the testes. As we say, the testicles, like at the very early days of the fetus, it is the intra-abdominal organ. But the testes has to travel from the abdomen into the scrotum. Why do we have to do that? Because of the temperature, yeah? The core body temperature, abdominal body temperature, core body temperature, abdominal temperature is human body temperature, which is 37. The spermatogenesis cannot take 37 degrees centigrade. It takes about 3 degrees less, and therefore the testis has to come out from the core body, abdominal cavity, and stay outside the abdominal cavity in a little pouch, which is called the scrotum. So this is the pathway. Look at that. This is the number 4 is the little testes before birth. So it is inside the peritoneal cavity. No, not inside, it is inside the abdominal cavity. And this is the blue colored. The blue color is called gubernacular testes. So which is the leading part, fibrous tissue from the testes into the scrotum here. That's number one, gubernacular testes. And look at the black colored peritoneum and the peritoneal cavity, which is color with the black. And when the testes come down, you can see that it pulls the portion of the peritoneum, which is black color. And this black peritoneum will form the tunica vaginalis. Hey, look at that. Look at that. You know, this big peritoneal fold being pulled by the testes to come and to follow the testes as the peritoneal fold. Look at that. And finally, it partially covers the testes as the tunica vaginalis. So if there is, finally, of course, these two tunica, this peritoneal fold, which is made of visceral peritoneum, parietal peritoneum, two layers of peritoneum, finally, we have to fuse. If that doesn't fuse, then we have the congenital hydrocele. Congenital, they are born with that hydrocele fluid filled in the scrotum, in the tunica vaginalis. Look at that. That is here the peritoneal fold. If there is these two layers doesn't fuse, then we have the fluid from the peritoneal cavity can track down along the inguinal canal into the scrotum, and that we present as the scrotal swelling, which is the hydrocele, congenital hydrocele. They might heal or they might not heal. So that is the last slide of the reproductive organ. So we have taken like about 3 lectures, like 2 hours each for the reproductive organ. That is quite a lot. Like it is just like, you know, like gastrointestinal tract, we talk about three lectures. But it is not just the reproductive system. It is included some of the embryology, which is the formation, gradual formation of the fetus. And it also includes the anterior abdominal wall, part of the anterior abdominal wall, which is the inguinal canal. Yes, this inguinal canal, it can be a little bit daunting, I would say, but it is important, especially the higher you go up, it becomes more and more important. Like if you do nursing school, they will crush you with this inguinal canal. If you do medical school, they will push you more with the inguinal canal because they know that these are the difficult parts to understand in human body, and they will keep asking you these questions again and again, again and again. And let me take a few minutes to revise this reproductive organ, and they start with the embryology. As we know, now we can see the ovary. Ovary is attached to the uterus with the ovarian ligament. Ovary is a retroperitoneal organ. It is not inside the peritoneum. Ovary is covered with the fimbria of the fallopian tube, and every month there will be 1 or 2 ovum come out as ovulation. And ovary has outer cortex and inner medulla. Inner medulla is just the blood vessels nerve, and outer cortex we will have the ovarian follicle, primary follicle, secondary follicle, and finally develop into mature ovarian follicle. Because of the surge, shoot up of the luteinizing hormone, this ovarian follicle will ovulate, and this ovulation, this little ovum will be picked up by the fimbriae of the fallopian tube and will go into the isthmus portion, and this remaining ovarian follicle will be left inside the ovary as the corpus luteum This corpus luteum is responsible for production of progesterone, which progesterone will give support for the endometrium in a later, after the follicular phase and luteal phase. Corpus luteum will provide this progesterone, and finally this corpus luteum will gradually regress. And this little ovum, which is being catched by the fimbria, will come into the ampulla of the fallopian tube and meet with the sperm and fertilization. This fertilized ovum gradually from 1 cell to 2 cell, 2 cell to 4 cell, gradually develop and develop. And day 3, as we know, there will be about 16 to 60 cells, and that is what we call morula. The whole fertilized ovum is filled with the small little cells, about 16 to 60. And in day 4, it will get into the uterine cavity. It will get into the uterine cavity at day 4. And once it gets to the uterine cavity, it will absorb water from the surrounding. And these cells will be pushed to one side, and there will be water on one side. This is what we call blastocyst. So day 4, the fertilized ovum is in the uterine cavity, and it is called blastocyst. Cyst means fluid-filled sac. So this one part of the sac of blastocyst is filled with fluid. The other part of the blastocyst is filled with the cell, and that is the covering of the blastocyst, which is what we call trophoblast. So this is blastocyst. If you look at more carefully, the cell portion and fluid portion and the covering is called trophoblast, and the cell portion is called inner cell mass, and the fluid-filled cavity is called blastocyst cavity. Look at that. That is day 4. And day 4, at day 7, it is trying to invaginate into the uterine endometrium. And we now know that endometrium has 2 layers, which is the basal layer and the functional layer. Basal layer doesn't change 24/7, 7 days, 24/7, 30 days, 12 months, 100 years you live, no, during your reproductive period, reproductive age period. But the functional layer of the uterine endometrium change with the uterine cycle. When there is menstruation, this functional layer will break down and come out as the menstruation. During the proliferative phase, this functional layer will be built up secondary to the estrogen, and after day 14, it will be maintained by the progesterone, and withdrawal of progesterone will give us the menstrual bleeding. So now we have the little conception, and it is now going into the uterine endometrium. A few little things to remember: conception, embryo and fetus. Of course, they are embryo and fetus, they are stay in the mother's womb. The pregnancy average takes about 38 weeks, and first 8 weeks is called embryo, and second 30 weeks is called fetus. Yeah, so fetus. So now you remember all this blastocyst is trying to invaginate the uterine endometrium. And now this trophoblast, which is the outer covering, which sit on the side of the inner cell mass, is going into the uterine endometrium. And this trophoblast gradually expand and develop into, on the cell side, cytotrophoblast, and in an invading site, syncytiotrophoblast. So now we got the syncytiotrophoblast and cytotrophoblast. At the same time, this inner cell mass will develop into 2-layer cell at 2 weeks. Yeah, 2-layer cells at 2 weeks. This 2-layer will develop into 3-layer at 3 weeks. And this syncytial trophoblast will invaginate into the maternal endometrium, and finally it will meet the maternal blood vessel, and this syncytial trophoblast will finally become placenta. Placenta, and the inner cell mass will gradually change into 2-layer cell mass, and it will create 2 sac, amniotic sac and the yolk sac. Yeah, amniotic sac and the yolk sac. Amniotic sacs will become the amnion, which is the membrane which the fetus lie, and the rupture of the membrane causes the break of the water breaks. That's what we say, water break. And this is developed from the amnion and from the inner cell mass and the 2-layer cell mass, and this yolk sacs will form the portion of the gastrointestinal tract. And if you look at that, this bilayer germ disc will gradually develop into trilayer germ disc. Look at that. Where are we now? Day 11. We have 2-layer germ disc already, and we have 2 cavities here: yolk sac and the amniotic cavity. Amniotic cavity will give the water back for the baby. Yolk sacs will develop into part of the gastrointestinal tract. And 2-layer cell mass is called epiblast and hypoblast. Epiblast and hypoblast. And this epiblast will invade and develop into the hypoblast, gradually forming more and more new cells and more new cells, and finally become endoderm, mesoderm, and the epiblast itself will gradually change into ectoderm, ECTODM, and the cell from the periphery gradually move into the center, and it form a little groove, which is called primitive streak. And at the tip of the primitive streak, we have a little bump, which is called primitive node. Look at the primitive streak from the just the AP superior portion, and look at the cross section. The cells are going centrally, and it forms a little groove, which is called the primitive streak. And at the tip of the primitive streak, it is called primitive node. And at the same time, epiblast is developing into the 3-layer, which is called ectoderm, mesoderm, and endoderm. Of course, from this primitive node, the cell ectodermal cell will gradually progress forward, and that these cells will become the brain and the spinal cord. And at the same time, this ectoderm, mesoderm, endoderm, this 3-layer germ disc will fold from side to side, will fold from top, head to tail, and finally we are going to get this sort of folding, and it will become the 2 tubular structure here. Inner tubular structure will develop into primitive gut, so gastrointestinal tract, which is going from the mouth to the anus, and at the same time, this inner tube will develop into respiratory tract, and outer tube will become the body cavity. It is so interesting. And finally, it just falls from head to tail, and it will gradually swallow the yolk sac. You can see the yolk sac gradually going into the little body cavity, and look at that. Finally, it will become the placenta. It will become the placenta cord. Yeah, placenta cord here. Finally, it will become placenta cord. And that's the yolk sac. And these are the two tubes, inner tube and outer tube. Inner tube is what we call the primitive gut. Primitive gut means early gut, which is, so 2 tube. 1 tube is the body, the whole body cavity. Outer tube is the whole body cavity, and inner tube is the inner gastrointestinal tract and respiratory tract. And these are the organs which develop from these layers. So it is easy to remember. The endoderm is the innermost layer, and therefore it is going to give the epithelium of the gastrointestinal tract. Look at that. The yellow endoderm is so much inside here, inside the inner cheek. The red color mesoderm is for mesoderm. Red color is for muscle. Of course, not just the muscle, all the big, strong structure like muscle, like bone, muscle, and kidneys, like big red solid structure here. And the bone here, the muscles here. And outermost ectoderm will develop into skin. And this ectoderm again will develop into brain and spinal cord. So that is the final result of this little folding and three-layer embryonic disc. And now we talk about the bony structure of the pelvic girdle, the ilium, sacrum, pubic, and ischium. Ischium is where we sit on. Pubic rami, so superior pubic rami, inferior pubic rami. And this is the ilium, sacrum, and this anterior point, anterior superior iliac spine, which can be easily felt on your body, and anterior inferior iliac spine, AIIS, anterior, which is difficult to feel, but you might be able to feel. So two spines in front of the ilium, which is called superior and inferior iliac spines, which is anterior. And you can see the pubic tubercle, which is the bony bone, and this is the pubic symphysis, where right pubic bone and left pubic bone come and meet in the center midline. We talk about the origin and insertion of the external oblique muscles, internal oblique muscle, and transversus abdominis muscle. And we talk about the arcuate line. Hey, arcuate line, where is it? Arcuate line is the midway between the umbilicus and the pubic symphysis, just somewhere around there. Why this happened? Because all the three muscles of the anterior abdominal wall below the level of arcuate line, they just go in front, below the level of the arcuate line. All these muscle layer of the anterior abdominal wall go in front of the rectus abdominis. Above the arcuate line, these layers of the abdominal wall, they just split and unite here. So now below the level of the arcuate line, we only have the transversalis fascia posterior to the rectus and peritoneum. That is the below the level of the arcuate line. And we talk a long time about this inguinal canal and the way it is formed. And what is the inguinal ligament? Inguinal ligament is the inward folding of the aponeurosis of the external oblique. That's all. And by splitting into two, it creates a little channel. That is what we call the external oblique aponeurosis. And we talk about the formation of the inguinal canal, and we talk about the Hasselbalch triangle. Hasselbalch triangle is the lateral border of the rectus, inguinal ligament, and the inferior epigastric artery, which makes the triangle. And this is the deep inguinal ring, So that's quite a lot. We spent quite a lot about this inguinal canal. And finally, that is what I have drawn here. This is the external oblique aponeurosis, which is attaching the anterior superior iliac spine, pubic tubercle, and around the pubic symphysis. And when coming down here, inferior layers of the external oblique just fold inwards to become the inguinal ligament, and it's split into here, and that is what we call the external ring. And from the external ring, this spermatic cord in male and the round ligament in female come out. This is the external ring. So now if I cut the external oblique, and fold it down, this is the remaining inguinal ligament. We have the internal oblique, which is colored with green, which is at the lateral side, it is attached to the external oblique. It just dome over the spermatic cord, and on the medial side, it comes posterior to the spermatic cord. And this internal oblique and the second layer, the transversus abdominis, combined as a conjoint tendon here. And of course, innermost layer is transversus abdominis, and the opening of the deep ring is in the transversus abdominis. Inguinal canal and the contents, the boundaries of the inguinal canal and the contents of the inguinal canals are all important, because when we do hernia surgery, hernia operation, or when you are seeing the patient with the hernia in the groin region, all these knowledge will come into play. So the inguinal canal contains spermatic cord, round ligament in female, and ilioinguinal nerve. All right, it's nearly 12 o'clock. And reproductive system, we talk about male reproductive system and female reproductive system. The primary reproductive system is testes in male, testes in male, and ovary in female. These, all the remaining ducts and glands, they are just secondary. Yeah. So if you want to know whether it is a boy or not, boy or girl, you have to look for the ovary or testes. I believe you have seen this slide again and again already. And the scrotum, testes, layer of the scrotums, it is important. Layers of the scrotum, it is important. The scrotum means it is a skin, outermost skin, and inner dartos muscle. Yeah, that is scrotum makes the dartos muscle, and the skin makes the scrotum. External spermatic fascia is coming from the external oblique aponeurosis. Cremaster muscle coming from the internal oblique aponeurosis. And transversus abdominis doesn't give any muscle layer inside. And the last transversalis fascia will give us the what do you call that? This internal spermatic fascia. So internal spermatic fascia is coming from the transversalis fascia. And of course, finally, we have the tunica vaginalis and tunica albuginea. Tunica albuginea is really stuck to the testes, and it invaginates into the testes, dividing the testes into different lobules. There are about 250 to 300 lobules, and each and every lobule is filled with the seminiferous tubule. Look at that seminiferous tubule here, very tortuous, loads and loads of long seminiferous tubule. Finally, it becomes straight to become straight tubule and go into the meshwork, which is called rectus testis, go into the epididymis, in the head portion of the epididymis, body portion of the epididymis, tail portion of the epididymis, and finally go into the vas deferens, tectus deferens. I want you to know the differential diagnosis of scrotal swelling, hydrocele, hematocele, varicocele, and hernia and testicular tumor. Right, so this is the seminiferous tubule. Seminiferous tubule has 4 cells: Sertoli cell, sperm-forming cell, smooth muscle cell, and Leydig cell. Leydig cells are interstitial cells. Sperm-forming cells, spermatogenic cells, they are just there, here and there. And Sertoli cell or sustentocyte, it's easier to remember as Sertoli cell. They are they will nourish the spermatogenic cells to form sperm. And this sperm will be coming into the central canal of the seminiferous tubule and gradually move towards the epididymis. All right, guys, I know it's quite a lot. I believe when you do the homeworks, it will become more and more clear. And you look at the slides and then go and do the homework. And that's the way, we try to remember all the lectures. So all the homeworks are important. Homeworks are something which, like, it is like a must know or should know topics. Must know and should know topics, which I want you to take for the next step of your education. All right. Has anyone got any question? Okay, then I believe you guys a little bit tired and fed up. All right, if you do not have any question, then I will let you go. And we will meet on Wednesday.